I've worked with the QR group for years, and again, when you want science on things, just sort of Google PubMed, QR, and you're going to see tons of every kind of data.
Treatments available are PRP and QR. These are some of my patients in the clinic. I presented 3 patients, both adults and 1 adolescent. So the first picture is a patient with female pattern hair loss. She was 28 years old. What was done, clinic QR sessions. I prescribed topical minoxidil and the patient refused. This was the results after 6 months.
With the hormonal changes may give us a good optimistic that hormonal changes may prolong the anagen or improve the hair. And this is, as Dr. Anwar mentioned, is not happening to all women, unfortunately. But reassurance of the patient, just we want her to go through that time safely for her and for the feet.
This protocol that I've initiated about 10 sessions, and I just continued with his own hairsprays that he always purchases, and I've compounded this combination of oral minoxidil 2.5 milligram with oral finasteride 1 milligram in a capsule.
And had a positive hair pull test to begin with, but wherein we observed increased percentage of club-shaped telogen hair across multiple scalp sites, which confirmed acute telogen effluvium. However, later through the course of the treatment, the subjective reporting by patients was encouraging. As you can see, they mentioned that the number of hair coming into the comb is much lesser. The clumps in the shower has disappeared. Of the QR678 Neo lies in the fact that the protocol is standardized and consistent and delivers a patented mix of polypeptides regardless of the patient's health. So the biological variability is out. That is what I think has driven the improvement.
Inviting me, I'm very happy to be part of this great panel. So I think that we are facing lots of unmet needs and challenges when we talk about androgenetic alopecia.
About the BMOS, the treatment is mandatory as early as possible.
Therapy justified in hair loss management, and how can clinicians avoid multiple treatment without clear evidence that each component is necessary? That's a tough one.
I think combination treatment is justified when there is a clear clinical evidence that will give extra benefit for my patient. In my point of view, it's dependent on to start combination therapy. Another point is proper diagnosis and investigation. With dermoscopy, sometimes lab investigation if needed also. If I see any vitamin and mineral deficiency, I can correct it.
Patient education is very important than all what we do for them.
Are there unified guidelines for management of alopecia across our whole spectrum, or are treatment decisions currently based on local regulations and individual clinical judgment?
New guidelines for treating pigmentation, hyperpigmentation, they include the combination therapy, also in practice, the mesotherapy, the whitening, when we inject the whitening needles.
I'm Dr. Raji Patil, the head of the medical team for QR678. QR678 is honored to sponsor Global Cosmetic Surgery HairTalks. Today, I will introduce 2 new frontiers to you, designed to rethink how we approach follicular science. In summary, the gold standard in hair loss management also has its challenges. How good it would be if these challenges were embedded. From the learnings of the Precision Re-Engineered Efficacy Optimization Framework, which is published in Stem Cell Research and Therapy Journal, has come the product QR678 Trio.